Okay, we shall start. So, കഴിഞ്ഞ പ്രസന്റേഷനിൽ എനിക്ക് തോന്നുന്നു കുറെ ആൾക്കാർക്ക് ഇത് നമ്മുടെ റെക്കോർഡഡ് സെഷൻ കിട്ടിയിട്ടില്ല എന്ന് പറഞ്ഞിട്ടൊരു ഇഷ്യൂ ഉണ്ടായിരുന്നു. സോ ഐ ഹാവ് ഇൻക്ലൂഡഡ് എ ഫ്യൂ ഇമ്പോർട്ടൻറ്റ് ക്വസ്റ്റ്യൻസ് ഫ്രം ദ പ്രീവിയസ് പ്രസന്റേഷൻ ഓൾസോ. ആൻഡ് സോ സ്ട്രെയിറ്റ് ആയിട്ട് പറയാം, നമ്മൾ നേരത്തെ പറഞ്ഞ പോലെ തന്നെ കഴിഞ്ഞ പറഞ്ഞ സെയിം ഇൻട്രൊഡക്ഷൻ തന്നെ എടുത്താണെങ്കിൽ റേഡിയോ ഡയഗ്നോസിന്റെ എൻ്റയർ തിങ് നമുക്കൊരു വി കനോട്ട് ഡിസ്കസ് ഇൻ 2 സെഷൻസ്. സോ മോർ ഓവർ ഇതിനകത്ത് നമ്മൾ ജനറൽ ആയിട്ടുള്ള റേഡിയോളജിയും സിസ്റ്റമിക് റേഡിയോളജിയും വരുന്നത് കൊണ്ട് തന്നെ നമുക്ക് എൻ്റയർ തിങ് ഒരിക്കലും ഡിസ്കസ് ചെയ്യാൻ പറ്റില്ല. സോ കൺസിഡർ ദിസ് ആസ് എ റിവ്യൂ ഫോർ ദോസ് ഹു ഹാവ് ഓൾറെഡി പ്രിപ്പയർഡ് റേഡിയോ ഡയഗ്നോസിസ് ആൻഡ് കൺസിഡർ ദിസ് ആസ് ആൻ ഓവർവ്യൂ ഓഫ് റേഡിയോ ഡയഗ്നോസിസ് ഏരിയ ഫോർ പ്രിപ്പറേഷൻ, ഫ്യൂച്ചർ പ്രിപ്പറേഷൻ. ആ രീതിക്ക് തന്നെ കൺസിഡർ ചെയ്യുക. ലൈക്ക് പിന്നെ പ്രസന്റേഷൻസ് എന്തായാലും ഷെയർ ചെയ്യും. സോ നോ നീഡ് ടു റൈറ്റ് ഡൗൺ എനിത്തിങ് ഫ്രം ദ പ്രസന്റേഷൻ. Just if you have a pen and paper, write down the areas, like areas you have to concentrate for further reading. Okay, so let's start directly with the question answer. So ഇപ്പോൾ കാണുന്നൊരു ഇത് തന്നെയാണ്, അതായത് ലൈക്ക് ദേ ആർ ആസ്കിംഗ് ഡീപ്പ് ഇൻ ചെസ്റ്റ് എക്സ്റേസ്. ചെസ്റ്റ് എക്സ്റേയിൽ ഓൾമോസ്റ്റ് ഓൾ ദ ഫെൽസൺ സൈൻസ് ആൻഡ് മെനി ചെസ്റ്റ് എക്സ്റേ ഫൈൻഡിങ്സ് ഹാസ് ബീൻ എന്താ പറയുക കോൺസ്റ്റന്റ്ലി ആസ്ക്ഡ് ഇൻ എക്സാംസ്. പലപ്പോഴും റേഡിയോളജിസ്റ്റ് PG പ്രിപ്പറേഷന് പഠിക്കുന്ന സെയിം സംഭവങ്ങൾ തന്നെ ഈ പറഞ്ഞ ഗോൾഡൻ സൈൻ ഒക്കെ നമ്മൾ PG പ്രിപ്പറേഷനും സ്ഥിരമായിട്ട് കേൾക്കുന്ന സംഭവമാണ്. അതേപോലെ തന്നെ നമുക്ക് എൻട്രൻസിന് ചോദിച്ചു തുടങ്ങുന്ന ഒരു ഇതിലേക്ക് വന്നിട്ടുണ്ട്. സോ ലെറ്റ്സ് ഡിസ്കസ് സം ഓഫ് ദ സൈൻസ്, ചെസ്റ്റ് എക്സ്റേ സൈൻസ് ആൻഡ് ഓൾസോ സം ഫെൽസൺ സൈൻസ് ഹിയർ. Some of the Felsen signs like Silhouette signs was already discussed in the previous thing, so I'll briefly touch upon. So first question is like golden as sign is seen in. So see, here I have just illustrated the S. This is the S, and actually it was described by a doctor called Golden, and here the S sign is actually reverse S sign, and here something is kept in the orange circle. So let's discuss golden as sign first. What happens here? നമ്മുടെ ചെസ്റ്റ് എക്സ്റേയിൽ, നോർമൽ ചെസ്റ്റ് എക്സ്റേയിൽ we can represent in the right side we can represent the horizontal fissure like this and the oblique fissure like this. Okay, we can represent like this. So what happens is when there is a right upper lobe collapse, so what we have to understand is whenever lung collapses, for whatever reason, for whichever reason, when lung collapses, it always collapses towards the hilum. It always collapses towards the center, that is hilum. But what happens here? Here the lung has collapsed. Here the upper lobe has collapsed, but still it is not collapsing towards the hilum because something is here. No, you can see some opacity here. So what happens here is there is a right hilar mass which is obstructing the right upper lobe bronchus, which results in the right upper lobe collapse. Since there is a hilar mass, the collapsed lung cannot collapse towards the hilum, and it is seen here. You can see as an opacity, and the horizontal fissure, which was supposed to be here, it is curving upside, and this side the bulge is due to the hilar mass. So this causes the reverse S, which is also known as the golden S sign. So what happens here is the hilar mass is obstructing the right upper lobe bronchus, which results in the collapse of the right upper lobe, which is seen as an opacity here. And as a result of the collapse, the horizontal fissure, which was supposed to be here, is moving upwards in this area. And this area, the horizontal fissure is bulging out due to the hilar lesion. So this is called as golden S sign or reverse S sign, which is classical and which is to some extent which we can call as a pathognomonic of right upper lobe collapse. So we have to concentrate here is there is a hilar mass which resulting in right upper lobe collapse. Hence, the lung is not collapsing towards the hilum. Okay. So next question is rib notching. Amongst the causes of rib notching are. So what we have to concentrate here is the theory part, which is rib notching itself. So rib notching can be divided. Okay. While learning in the PG classes, in spotter session, we always say ഇങ്ങനെ തരില്ല ഒരിക്കലും. PG entrance അല്ല, PG എക്സാംസ് വരുമ്പോൾ ഇങ്ങനെയാണ് തരുന്നത്. They will give an entire chest X-ray, and usually what happens is we won't be able to pick up any finding. So നമ്മുടെ പ്രൊഫസർ സ്ഥിരം പറയുന്ന ഒരു സംഭവമാണ്, when we are not able to pick up any finding, look in the hidden areas of chest and also look in the rib area. You can see a subtle notching here. See, some notching is here, and you can also see some notching here. So just imagine what all can cause rib notching. There are n number of reasons that can cause rib notching, but see, some of the reasons we should know. Like rib notching can be divided into up superior rib notching as well as inferior rib notching, and we know that inferior rib notching, there are some of the structures that pass just adjacent, or so just inferior to the ribs are intercostal vessels, intercostal neurovascular bundles, right? So there are veins, there are arteries, and there are nerves. So now you can just imagine some pathology of the intercostal neurovascular bundle, which results in either bulging or swelling, or some nodular lesions in the intercostal vascular bundles. If it is present, it will definitely cause rib notching, underside rib notching. Okay, so here just imagine. So the answer is obviously all of the above, right? See, coarctation of aorta. If there is coarctation of aorta or aortic arch syndrome or some congenital anomalies with the in the aortic arch area, what happens? It will form collaterals. It forms collaterals, and similarly, when there is chronic superior vena cava obstruction, also it will form collaterals, which result in either engorgement or swelling of the intercostal arteries or veins, which can cause rib notching. So here the cause is coarctation of aorta, congenital interruption of aorta, aortic arch syndromes result in rib notching by the intercostal arteries, and chronic superior vena cava obstruction cause notching by the intercostal veins. Some other examples would be what? Neuroma, acoustic, vestibular, neuromas, schwannomas, neurofibromas, etc., which cause swellings along the nodular swellings along the intercostal nerves that can also cause inferior rib notching. So next question is always remember there are mainly three type of questions regarding investigations. Mainly one, what will be the next investigation, what will be the investigation of choice, and what will be the gold standard investigation. So always when you see an investigation question, these three things should come into your mind. Always there won't be questions there won't be questions or answers for all the three, but be very careful while answering these type of questions. So here in aortic dissection, investigation of choice is. So there is a small confuser here. ECG and MRI scan, I don't think anyone will consider. CT scan and aortography. See, usually in aortic dissection, the investigation of choice or next best investigation would be CT aortography, which is a contrast enhanced CT scan. Okay. Otherwise, if we strongly suspect aortic dissection from a chest X-ray or a CT scan, we'll go for direct digital subtraction angiography of the aorta, which is also aortography. So here the answer either would be CT angiography or CT aortography or proper aortography itself. We have not mentioned it is CT aortography or MR aortography or conventional aortography. We have just mentioned aortography. So the investigation of choice of aortic dissection can either be CT angiography or CT aortography or aortography itself. Whatever it be, it should be a contrast-based investigation that can clearly depict the aortic vascular lumen. So here the answer would be aortography. Next question. These are some of the commonly asked questions always. Like beheaded Scottish Terrier sign is seen. So what is this beheaded Scottish Terrier sign? So this resembles a dog, right? So this is the Scottish Terrier dog. So what is this beheaded Scottish Terrier dog? See, this is the vertebral column. This is X-ray of the vertebral column, which has vertebrae, and these are the posterior elements, which has the transverse process and means spinous process, and also this is what we call as the facet joint, right? Where the superior articular facet and inferior articular facet forms a joint. Actually, this joint keeps the vertebrae from dislocation, from going anteriorly or posteriorly. So see, this is the This is the area what we call as pars intermedia or interarticularis. So this is formed by the facet joint. So whenever, see, so whenever this is also the facet joint. This is the depiction of the Scottish Terrier dog. So whenever there is a listhesis, like one vertebra going over the other, this head region will break. So that is the reason for this beheaded Scottish Terrier sign. Here, this spondylolysis just means there is a break in the pars interarticularis. Okay. Then it won't produce this beheaded appearance. Beheaded appearance will only be produced when there is a listhesis, that is a relative movement between the vertebrae. The fracture of transverse process, fracture rib, fracture scaphoid, these are all just misleading things. You won't even consider, I think. So this is spondylolisthesis is the answer. For spondylolisthesis to occur, there will be spondylosis or spondylolysis. Okay, this is just spondylosis. Another confuser would be spondylolysis. Spondylolysis also means that there is just a break in the pars interarticularis. Only when there is a spondylolisthesis, that is a relative movement, anterior or posterior, there will be this appearance. See, there will be a break. When there is a listhesis, there will be a break in the neck. Hence, the term beheaded Scottish Terrier sign. Next is a straight away question. This radioactive cobalt emits. Even though we are discussing radiodiagnosis, radiotherapy, many questions from radiotherapy also. Radiotherapy as well as nuclear medicine also comes under this. They usually ask this. So previously, in the previous presentation, we discussed many nuclear medicine studies like parathyroid sestamivir scan. So this is another area which also is being asked under radiodiagnosis itself, because there is some relation, right? So this is radioactive cobalt emits. So radioactive cobalt is used for cancer care usually. So this is used for cancer care by producing gamma rays, which is used to destroy the cancer cells. So you might have already heard this gamma. You might have heard gamma knife surgery, this radio surgery, etc., which are very precise radiotherapies given for tumors, AV malformations, etc. So these gamma rays are produced by radioactive cobalt in medical field. Okay. Another question is maximum penetration is seen with. So it is also like gamma rays are used for treatment because it has the maximum penetration. Okay. Alpha and beta rays do not have much penetration, especially alpha rays can even be stopped with some cardboard. Electron beams have some penetration, but still it is mainly used in the surface area like skin cancers, etc. So the maximum penetration is seen with gamma particles. Okay, alpha, the order will be like alpha, beta, gamma, and neutrons, and electrons will come somewhere here. Okay. So this is yet another very favorite question from the exam perspective, both in undergraduate entrances as well as PG radiodiagnosis PG exams. Like they want us to know all the signs in X-ray regarding hydatid cyst. Okay, so this is just one example to let you know that the hydatid cyst area you have to study all the signs. So this is the water lily appearance in chest X-ray is suggestive of. This is chest X-ray where you can see a cavitating lesion. You can see an air fluid level, like there is air upwards, there is fluid downwards, and there you can see some projections here as if they resemble water lily in a pond. Okay, this being the pond and this being the water lily. I don't know how the resemblance is, but it is named so. Okay, so this is actually what hydatid cyst, which has ruptured and it is contained. Why I'm using the terms? Usually a well-defined hydatid cyst which has not ruptured won't produce this appearance. Okay, if there is a hydatid cyst which is well-defined and not ruptured, it is completely filled with fluids and daughter cells, which will be a homogeneous opacity, relative homogeneous opacity. When there is a rupture and it is contained, see, it is still contained, but it has ruptured, then there would be air in the upper part and the fluid, the hydrated fluid in the lower part. And what are these projections? These are daughter nuclei or daughter cells within the hydrated cyst. Okay, so what really appearance in hydrated X-ray is suggestive of ruptured contained hydrated cyst. It's an obvious question, just telling most radio dense substances. So most radio dense substance among this will be bonds, right? It will be like fluid. Fluid will be the least will be least radio dense will be air followed by fluid, right? And then soft tissue and brain, then only bone. And if something is higher, what will be? It will be the metallic implants or metallic foreign bodies, which will be more dense than bone. So most radiodense among these would be bone, and if the metallic implants also there, that would be the answer. Okay, now the acute radiation sickness is characterized by. What is acute radiation sickness? If somebody is getting exposed to a huge amount of radiation within a short span, then it will be producing this acute radiation sickness. Actually, it will produce hematological symptoms, it will produce CNS symptoms, gastrointestinal symptoms. Hence, the answer will be all of the above. I think many of us might have seen that Chernobyl docufiction. In that, everything has been depicted clearly. So that is because of radiation sickness. Just a brief outline about the radiation sickness. It has mainly 3 to 4 phases. Like there will be a prodromal phase, there will be a latent phase. When there is an apparent improvement in the symptoms, then there will be a proper symptomatic phase, which will finally lead to either recovery or death. So regarding radiation, everything you have to be understanding, like starting from acute radiation sickness to the effects of radiation, which is stochastic and deterministic. We have already gone through this in the previous slides. Just read about the effects of radiation, which is characterized into stochastic and deterministic, and answer accordingly. So next question will be, premature filling of veins is a manifestation in cerebral angiography of. So just understand this. When we do an angiography, okay, this is not something like ultrasound or CT or MRI. We are just mentioning about proper conventional angiography. It is done now as digital subtraction angiography. You might have seen many images. So it usually how it is done, we'll puncture an artery either in the upper limb or lower limb femoral artery. We'll go to the corresponding place. Like in cerebral angiography, we'll go to the carotid vessels and we'll selectively catheterize the vessel of interest. Then we'll inject one dye in the artery, which go to the capillaries. Then it will go to the veins and come back to the heart and go into the circulation and later gets washed off. So when will there be a premature filling of the veins? See, we are injecting into the arteries, right? So when will there be a premature filling of the veins? When there is a direct communication between artery and vein, bypassing the capillaries, there will be premature filling. So among this, the answer will be, the best answer would be arteriovenous malformation. Why the best? Because in some cases, like in trauma and all, there can be formation of arteriovenous fistula. Arterious venous fistula can also cause premature filling. So don't get confused with these options. There will be premature filling of veins when there is a direct communication between artery and vein, bypassing the capillaries. It can be there in arteriovenous malformations, or it can be there in arteriovenous fistula. Next question. I think some of the questions, there is overlap between the previous presentation and this one because the recording was not available. I think this question was discussed previously also. Ultrasound diagnosis all the following except. Actually, this is somewhat a straightforward question, but there is a confuser here. See, actually, when we think of obstetric ultrasound, okay, in first trimester ultrasound itself, when there is no cranium or there is no brain parenchymal tissue, we know that there is anencephaly. So ultrasound diagnosis is this one. ultrasound is used to diagnose this placenta previa. There won't be any confusion, and this one highlighted for more. There won't be any confusion. Here comes the confusion because Down syndrome, we do Down syndrome screening in the 11 to 14 weeks, right? First trimester, I mean 3-month scan. But see, ultrasound doesn't diagnose Down syndrome. Ultrasound just screens for Down syndrome. We screen for Down syndrome with ultrasound using something called as nuchal translucency, which is a small fluid collection in the nuchal area, in the behind area of the neck. And we also look for many other soft markers. We look for nasal bones. We do like ductus venosus study. But we are not actually diagnosing Down syndrome. Rather, we are just screening for Down syndrome risk. When we see that there is an increased risk for Down syndrome with these ultrasound parameters, we go for karyotyping or further evaluation, including karyotyping. Okay, karyotyping or this fish amniocentesis, etc. So we are actually not diagnosing Down syndrome. We are with the ultrasound. We are screening screening for Down syndrome for assessing the risk. Next question is just clinical scenario questions are being asked increasingly from radiodiagnosis part also in the previous exam. So just let's touch upon a few. An elderly man presents with a history of jaundice and pain abdomen. The investigation of choices. Usually, what we see is from these kind of questions, we usually tend to over answer. Like we go for higher investigations. Okay, here an elderly man presents history of jaundice and pain abdomen. There's just acute abdomen is there. There is history of jaundice. The investigation of choice or the next investigation would be ultrasound from the list. Okay. When because see jaundice, we all know that most of the cases jaundice will be due to the malfunctioning of liver, and there is pain abdomen also. There are many cases where there can be jaundice and pain abdomen. May it be cholangitis, may it be there some distal obstruction of the CVD resulting in obstructive jaundice. There are multiple causes. So whenever we see jaundice and pain abdomen, we always suspect when we want to rule out any pathology of the hepatobiliary system. So it's the first investigation of the next investigation would be ultrasound. Okay. Only with the ultrasound, if we are suspecting something like a distal CVD mass or distal CVD obstruction or some periambulary carcinoma, we'll go for next evaluation, like maybe CCT abdomen or MRCP. So here the answer would be ultrasound. Hilar lymphadenopathy is one of the favorite areas still asked in exams. Actually, even though we say that these are typical of this, in actual clinical scenario, we usually see both ways. Okay. So what I want to say is bilateral symmetrical hilar lymphadenopathy is seen. Okay, when we usually use the term bilateral symmetrical hilar lymphadenopathy, we go for sarcoidosis. Okay, in exams we go for sarcoidosis. Tuberculosis is usually asymmetrical. Okay. Another question: a patient has calcification on AP view of right side of abdomen. In lateral view, the calcification is seen to overlay the spine. The most likely diagnosis. Actually, they have described just applying common sense itself with the basic knowledge of anatomy, you can answer this question. Okay, there are only two confusers. I mean, basically two confusers here. One is gallstones or renal stone or calcification. Okay, patient has calcification on AP view of right side of abdomen. Actually, anything can be here. Mainly, since they are referring to right side, this gallstone will be coming right renal stone. To some extent, mesenteric nodes also. But calcified mesenteric nodes are relatively on the rarer side. So we'll get a confuser between gallstones and renal stones mainly. So in lateral view, the calcification is seen to overlay the spine, rules out what? Gallstones. Okay, gallstones. See, according to, I mean, just imagine the anatomy of the gallbladder. It is projecting anteriorly and anteroposteriorly in the underside of liver, right? So it won't, in the lateral view, it will be more anteriorly placed from the spine. So here the answer would be renal stones or calcification. This is it's an example from the left side. When there is a left large calculus or left renal calcification on the lateral view, it will definitely overlap the spine. So next question, characteristic finding in MRI scan of patient with tubercular meningitis. Okay, tubercular meningitis or tubercular cerebral infections has many manifestations, but characteristic finding in a tubercular meningitis would be due to the basal cistern exudates. Okay, there will be if you see something like basal cistern exudates or basal exudates, directly go for tubercular meningitis. It is most commonly seen tubercular meningitis. Some other conditions are also there. Actually, in MRI scan of tubercular meningitis, there can be hydrocephalus due to obstruction. There can be ventriculitis, but the characteristics finding will be exudates in the basal cisterns. It will it will appear like this. Actually, this is a contrast enhanced MRI. See, when there are exudates in the basal cisterns, there will be contrast enhancement of the adjacent areas also. So this is the pattern of basal exudates seen in MRI. So next is basically a small conceptual question. An obese patient has heavy, thick bones. A good X-ray is taken with. Actually, you need to understand a few concepts regarding KVP and MA. So how is an X-ray produced? I think in the previous class, one thing was on X-ray tubes. So just brief outline. So there are mainly two parameters. So I'm just oversimplifying. Okay, there are two parameters that determine the characteristics of X-ray. One is the MA. What is the KVP? What is MA? One is basically milliampere, which is the current given to the coil that produces electrons, which in turn produces X-rays. Okay, MA is the current that is supplied to the tungsten coil that produces electrons, which when hits a target produce X-rays. So when you increase MA, what will it increase? It will increase the number of electrons released from the coil. So when number of electrons increase, it will indirectly increase the number of X-rays. So what can we infer? When you increase milliampere MA, it will increase the number of X-rays. When number of X-rays are increased, it will produce it will produce more darker images, right? When number of X-rays are increased. So next one is KVP, which is voltage supplied across the anode and cathode, which accelerates the electrons produced from the cathode. So whenever you increase KVP, it is the voltage. What happens? It will produce X-rays with more energy because the electrons are accelerated. When you increase the voltage, the electrons gets accelerated, which will hit the target, which produce X-rays with more energy. When there is more energy, it will have more penetration. It will penetrate more into the body of the patient. So inferring MA when increased, it increases the number of electrons, it increases the number of X-rays, which darkens the image. When you increase KVP, it increases the energy of the electrons, which in turn increase the energy of the X-rays, which in turn produces more penetration. So an obese patient has thick, heavy bones, and a good X-ray is taken by increasing in the KVP. Okay, because it has more penetration. The only problem with increased KVP, it will produce less resolution. Okay. I'm not explaining in detail the physics regarding this. Just understand these concepts. KVP increases penetration, hence it can be used for obese patients. But whenever you increase the KVP, you increase it on the cost of resolution. Okay. So all of the following are true about loculated pleural effusion. This also we have actually mentioned the previous question, just repeating it because it's some basic concept is happening here. See, you have to make sure that whenever you are seeing a lung field in a chest X-ray, you are actually seeing together the lungs as well as the pleural space. Okay. And whenever there is a consolidation, whenever there is I'm not mentioning lesion, I'm just mentioning consolidation. You might have already heard the term air bronchogram. Okay. Air bronchogram means the air within the bronchus, which is seen through a lesion, which is seen through a consolidation. So when there is a consolidation within the lung parenchyma, there can be air bronchogram. So when you see air bronchogram, in a chest X-ray, you know that the lesion or that consolidation, that opacity is within the lung parenchyma. Okay. Next thing, next important thing is whenever you see some fluid or some effusion in the pleural space, you know that it usually produces this S-shaped appearance, right? Like due to the capillary action, you have some sloping here. You will have some sloping here. So whenever there is a loculation of the pleural effusion, it will produce an obtuse angle with the chest wall. Otherwise, it won't. Okay. Here, it will produce an obtuse angle with the chest wall because it is a loculated effusion. No, loculated means it is loculated to the chest wall. So it will produce an obtuse angle with the chest wall. The margins are very clear when viewed in end phase because of the localization. It is not confined to any bronchopulmonary segment. See, bronchopulmonary segments means the segments of the lung. Here we are mentioning about loculated pleural effusion. So pleural effusion is outside the lung, so it won't be confined to any bronchopulmonary segment. Here the answer would be what? Air bronchogram is seen within the opacity. See, loculated pleural effusion is within the pleural space. Hence, air bronchogram cannot be seen. Air bronchogram will be seen when an opacity is within the lung. No? Here, it being in the pleural space, air bronchogram won't be seen. So all of them are true except air bronchogram is seen with no opacity. Air bronchogram cannot be seen. Okay, this is just an anatomical question. Actually, these images are slightly magnified. Okay, chain of lakes appearance on X-ray is seen. Magnified in the sense the rest of the part is not seen. But see here, chain of lakes appearance on X-ray is seen. See, this is the classical appearance of pancreatic calcification. When we place pancreas in our abdomen, like it will come like this, no? See, it will cross both sides of the both sides. The pancreas is placed. It has parts on the right side as well as on the left side of the vertebrae, and also there is a slight sloping because pancreas is placed like that. So whenever you have this pancreatic calcification, or there is pancreatic calcification, that any pathology that you can see in the X-ray of the pancreas, it will cross to the right as well as left of the vertebrae. So here, chain of lakes appearance is the classic appearance seen in pancreatic, chronic calcific pancreatitis. Okay. So the answer would be chronic pancreatitis. Chronic pancreatitis leading to calcifications within the duct as well as the pancreatic parenchyma is seen as chain of lakes appearance. Next one, you have to understand, this is a question for you to read up the borders of mediastinum. There are many questions being asked on this. On chest X-ray, right border of mediastinum is formed by all of the following except. Okay, let's again discuss. The same question was discussed in previous one also. See, this is the right side, right border of the mediastinum, and this is the left border of the mediastinum. Right border is formed with right paratracheal stripe. See, this is the trachea, this is the paratracheal region. Here in the paratracheal region, there will be coming superior vena cava also. In this region, there will be superior vena cava, and this is the area of the asparagus, and this is area of the right heart border. Okay, so right heart border is actually formed by right ventricle. There is no right atrium for right heart border. So when we talk about right heart border, it is formed by the right ventricle. When we talk about the right mediastinal border, there is superior vena cava. There is right paratracheal stripe. There is superior vena cava. There is right heart border formed by the right ventricle. There is no right atrium. Okay. Sorry, actually, yeah, I think there is a mistake. You understood, right? There is the answer is right atrium. Okay. The best investigation for pericardial effusion is? Actually, there is a small confuser here. I think you will all write echocardiography as the answer, but there is a slight confuser here. What it is, because echocardiography is also a form of ultrasound, right? So best investigation for pericardial effusion, from these, it would be echocardiography. If there was no echocardiography, you might have written ultrasound USG. So here the answer is echocardiography. Next is acoustic shadow on ultrasonography is due to. There is a small confusion. You already know that acoustic shadowing on ultrasonography is usually seen with what? Stones. When there are calcifications or anything that doesn't allow sound to pass through, it will produce acoustic shadowing in the distal portion. So this is an example of acoustic shadowing, which is produced by gallstones, right? When there is a calcification or stone, when ultrasound passes through the abdomen and hits the calcified area or the bones or anything that doesn't allow ultrasound to pass through it, then it will produce a dense hypoechoic area, black area posterior to it. This is basically due to reflection. Okay. Here the confuser will be artifact. Why the confuser is an artifact? Because an ultrasound, this posterior acoustic shadowing is actually an artifact. This is actually an artifact, but the artifact is due to reflection here. There are many other artifacts in ultrasound, but this artifact of posterior acoustic shadowing, when there is something like a stone or there is a foreign body, there are bones, there is air, anything will cause reflection of the ultrasound, which results in this acoustic shadowing, which is actually an artifact. So it is due to reflection. Okay. The earliest sign of fetal life is best detected by. You know that it is earliest sign of fetal life is actually the cardiac activity. The cardiac activity is detected by ultrasound itself. It's detected by normal early obstetric ultrasound. There is no need of fetal echo. Okay. Fetal echo is used to assess the heart in the anomaly scan region, like maybe in the 20-week region. It is not the earliest sign of fetal life because fetal echoes are done for ruling out any cardiac anomaly of the fetus. Okay, earliest sign is just the cardiac flicker or cardiac beating, which is seen with ultrasound itself. Next question: CT scan shows a subarachnoid hemorrhage following symptoms of sudden headache and paralysis. Next investigation of choice is. In the previous presentation, we already saw the detection of extradural hematoma, subdural hematoma, subarachnoid hematoma, hemorrhage, etc. Because it's also becoming a favorite question, especially in the previous NEET. The question was very confusing between extradural and subdural hematoma. Okay, so you have to concentrate on that area. We'll come across in another question also. So CT scan shows a subarachnoid hemorrhage and it follows sudden headache and paralysis. So the next investigation of choice will be what? It is a 4-vessel angiography. 4-vessel angiography, it is like digital subtraction angiography of the head and neck region. That is a 4-vessel angiography. It includes both carotids and its branches and also the vertebral arteries. That is hence the term 4-vessel angiography. Why 4-vessel angiography? Because when there is a subarachnoid hemorrhage, if there is no history of trauma, the most important culprit of subarachnoid hemorrhage will be berry aneurysms or any aneurysm. Okay. So in order to diagnose as well as treat aneurysm in one go, the best or the gold standard investigation will be a 4-vessel angiography. Next is the best method to diagnose bronchiectasis. What is bronchiectasis? Bronchiectasis is actually the irreversible permanent dilatation of the bronchus. So the best method, so to some extent, you can actually diagnose the X-ray. Okay. But the best method to diagnose bronchiectasis would be HRCT, high resolution CT. Bronchiectasis, usually it has many signs, but in your level, you can just imagine this dilated bronchus. Okay. Next question is Coles popcorn calcification on mammogram is due to. Okay. Here we can see a mammogram, which is in mammogram, usual views are one is the mediolateral oblique view and craniocaudal view. Here you can see the MLO means mediolateral oblique view. This is a mammography, which is a X-ray mammography. See here the popcorn calcification. See, this is the popcorn calcification. You can see an opacity, a well-defined lesion here. And within that, there are multiple coarse popcorn-like calcification. Okay, this is actually very characteristic of fibroadenoma. There are many lesions which show popcorn calcifications in radiology. So here in breast, the most important lesion which show popcorn calcification is fibroadenoma, which is depicted here. Okay, it is a benign tumor of the breast. Usually when we see popcorn calcifications in a breast lesion, whenever we see a breast lesion, we get alarmed, right? But whenever we see a popcorn calcification in a breast lesion, we know that it is going to be benign. It is a typical involuting fibroadenoma. So next question, which of the following is less useful diagnostic procedure in case of acute hematemesis? See, it is not just hematemesis, it is acute hematemesis. Okay. In acute hematemesis, which of the following is less useful? See, here, when you read everything, you will feel that everything is useful. See, varimeal is useful. Varimeal anyway visualizes the stomach. Endoscopy is useful. Gastric content aspiration will be useful. Angiography is useful. Why angiography is also useful? Because angiography, if there is a bleeder, right? Hematemesis means some bleeder will be there, right? When you do angiography, there is continuous hematemesis. When you do angiography, you can find a bleeder vessel. But see, barium meal is not very useful in an acute hematemesis setting. In acute hematemesis, their hematemesis is ongoing and there is continuously blood is coming in. So you can do gastric enteral aspiration, endoscopy, ligate, angiography may be done to see extravasation from any vessel, but there is no need for what? Barium meal. Barium meal is not usually done done as an acute procedure. Okay. So in acute hematemesis, less useful would be barium meal. Next question, the method to diagnose displaced intrauterine device. So it is a very important area in gynecological practice. Like many times their patients will come with missed, they say that the copper T thread is missing. They are unable to identify the thread and we usually suspect what displaced intrauterine device. There need not be displacement. It might be within the intrauterine area, but the thread is missing. So we have to diagnose whether there is a displaced intrauterine device or whether there is in place. So the method to diagnose displaced intrauterine device would be what? Ultrasound. Ultrasound can diagnose. Now, to some extent, ultrasound is used to visualize the uterus X-ray abdomen. By X-ray abdomen, sometimes the displaced intrauterine device will be displaced to the abdomen. The intrauterine device many times will be radio opaque, like copper T, etc., will be radio opaque, and you can see from the X-ray abdomen, uterine sound and hysteroscopy. You can directly visualize the endometrial cavity. Hence, the answer would be all of the above, right? Here, if it was like the method to diagnose displaced intrauterine device, in spite of this, if they are giving many other options also, and what sometimes something like this, a patient is coming and you are suspecting displaced intrauterine device, the next investigation would be, what will be the next investigation? It will be the ultrasound, because it is easily available and it can easily be done, right? Without any radiation exposure, nothing. So ultrasound will be the next best investigation. But in this case, all can be, all are useful, hence all the above. So, okay. There are skull X-ray based questions are frequent in entrances. There will be questions regarding multiple punched out lesions. There will be questions regarding hyperparathyroidism. There will be questions regarding geographic lytic lesions. So here we'll address one. Geographic lytic lesion in the vault of the skull with beveled edges are seen. See, this is the geographic edge, lytic lesion. What is lytic lesion? Lytic lesion is a loosened lesion, right? Here, skull. Here is the skull, and this will be the appearance of the skull bones. And when there is a lytic lesion in the skull, it will appear like a hole, like what's a hypodense area. So when you see the term geographic lytic lesion, you have to remember that it will be eosinophilic granuloma. See, usually this type of geographic lytic lesions will be single in eosinophilic granuloma. It will usually the X-ray of a child. In multiple myeloma, what will be the appearance? Multiple myeloma, there will be multiple lesions, multiple punched out lesions, small, similarly appearing multiple punched out lesions in multiple myeloma. To some extent, in brain, skull secondaries from follicular carcinoma, thyroid, or RCC, skull secondaries can also produce some multiple lytic lesions. To some extent, it will resemble multiple myeloma, but in case of secondaries, the lesions will not be very similar. Okay, so here the answer will be eosinophilic granuloma. In case of lytic lesions, always remember this: a geographic single lytic lesion, you have to remember eosinophilic granuloma. Multiple punched out lesions, you have to suspect multiple myeloma, and the another BD would be secondaries. Another question: a young man with pulmonary tuberculosis presents massive recurrent hemoptysis. For angiographic treatment, which vascular structure should be evaluated first? Okay. In case of hemoptysis in a tuberculosis patient, actually, where is the bleeding coming from? Actually, it is coming from the pulmonary, coming from the bronchial artery. Okay. So, bronchial artery is the culprit in the hemoptysis of tuberculosis. So the angiographic treatment, the first structure to be evaluated is the bronchial artery itself. So we do angiography of the bronchial artery. We do we can do many other procedures like embolization, etc. Bronchial artery embolization has been on the rise due to this interventional radiology getting developed. Okay. Next question: a 55-year-old who has been on bed rest for the past 10 days, complaints of breathlessness and chest pain. The chest X-ray is normal. The next step in investigation should be. Okay, see, there are a few clues here. There is sudden onset breathlessness and chest pain, which can be cardiac or pulmonary, or many other causes will be there, right? But whenever we say that the patient is on bed rest for any reason, what will we suspect? We definitely have to suspect what? Deep vein thrombosis. See, the patient is on rest. There can be deep vein thrombosis, and complaints of breathlessness and acute onset chest pain means we are suspecting pulmonary embolism from the DVT. It is actually an indirect question, right? The chest X-ray is normal. Actually, in case of an acute pulmonary embolism, there are many chest X-rays defined, but in majority of the conditions, the initial evaluation, the chest X-ray will be normal. So the next step in investigation would be what? A pulmonary angiography. Okay. To be more precise, it will be a CT pulmonary angiography. Lung ventilation perfusions can be done in case of suspected pulmonary embolism. In case of it will show ventilation perfusion mismatch and all, but still the next step in investigation, or the investigation of choice, would be pulmonary CT pulmonary angiography. Why? Because it can directly depict the occluding thrombus within the vessel. We can see the vessel. Here it is basically we are not seeing the vessel. It is like a ventilation perfusion mismatch. It is a color coded map we are getting. We cannot definitely say that this is due to pulmonary embolism. There can be multiple conditions, but here the answer would be pulmonary CT pulmonary angiography will be the next or best investigation in case of pulmonary embolism, in case of a patient suspected DVT having a breathlessness. Okay. Next question. A 25-year-old man presented with fever, cough, expectoration, and breathlessness of 2 months duration. Contrast-enhanced computed tomography shows bilateral upper lobe fibrotic lesions, and mediastinum has enlarged necrotic nodes with peripheral rim enhancement. Which of the following is the most probable diagnosis? Here, just see that there is a 2-month duration fever and cough. Where definitely, we usually suspect tuberculosis in our country. Okay. But still, there is a bilateral upper lobe fibrotic lesions. Okay. Bilateral upper lobe fibrosis. usually in tuberculosis, we have primary tuberculosis, secondary tuberculosis. We being an endemic country for tuberculosis, many times tuberculosis be come undetected and go, or it can be detected, it can be treated, and which it will give fibrotic sequelae in the upper lobes. And later, when it gets reactivated, there will be multiple lesions, including mediastinal lymph nodes. Here, the only catch is enlarged necrotic peripherally enhancing mediastinal lymph nodes. When you see mediastinal lymph nodes which are necrotic, you have to answer tuberculosis. Okay, TB is the answer. See, bilateral symmetric hilar lymph nodes. When you see, you have to write sarcoidosis. When you see necrotic mediastinal lymph nodes, you have to write tuberculosis. Which of the following is the best choice to evaluate radiologically a posterior fossa tumor? See, posterior fossa means posterior fossa of the intracranial posterior fossa. Okay, intracranial region. Intracranial region posterior fossa tumors like mengiomas, schwannomas, or any tumor, medulloblastoma, any tumor of the cerebellum. When there is mention of posterior fossa, see, the answer should be MRI rather than CT. Why? Because in case of CT scan of the posterior fossa, there will be many artifacts. You might have heard during your house surgeries that it is difficult to evaluate for posterior fossa strokes with CT because there are multiple artifacts. The same is the case with posterior fossa tumor also. Whenever you want to see the posterior fossa in detail, you prefer MRI or CT. So the answer here will be MRI. For the evaluation of blunt abdominal trauma, which of the following imaging modality is ideal? See, this is actually a confuser. Why? Because when you suspect blunt abdominal trauma, the next investigation would be ultrasonography, FAST or EFAST, using ultrasonography to detect any fluid. But when you know that there is a blunt abdominal trauma, and what is the ideal or what is the best or what is the investigation of choice for assessment of abdominal blunt organ injury, then the answer would be computed tomography, more precisely contrast enhanced CT. Contrast enhanced computed tomography can detect, to some extent, it can detect fluid. It is also able to characterize the lesions, like what is the grade of the injury. You have seen AAST grading of liver injury, splenic injury, and other organs. So it not only just gives information whether there is fluid or not, it will point out the organ that is involved, and also it will help us grade the injury, which help for further treatment option, like whether surgery is needed, whether the patient can be conservatively managed with proper observation and all. So the next investigation will be ultrasonography FAST. The best, the ideal or investigation of choice will be CT, precisely CCT. The gold standard for diagnosis of osteoporosis. As you know, osteoporosis, there are multiple primary and secondary causes of osteoporosis. Osteoporosis just means that there is reduced bone density. And the gold standard for diagnosis of osteoporosis is dual energy X-ray absorptiometry, shortly called as DEXA. Okay, so it is DEXA for osteoporosis. The right lobe of the liver consists which of the following segments? Actually, you know that for assessment of for characterizing, not just characterizing, for localizing lesions of the liver or any localizing the liver injuries, we usually use the terms like it is localized to a segment. It is known as Queenard segment, right? So the right lobe of the liver consists of which of the following segments? So just understand the Queenard segment, like the left lobe consists of, this is the caudate lobe, right? First is the caudate lobe, then in the left side it will be 4A, 4B, 2 and 3, and on the right side it will be 5, 6, 7 and 8. It is usually given in this order: 2, 3, 4, 5, 6, 7, 8. The division is based on the portal vein branching, and whatever above the portal vein branches are termed as the upper segments, and below is the lower segments. And here you can see this one, no? the middle hepatic vein, lateral to this will be the right lobe sequence and left lobe sequence, and also the falciform ligament. This is a falciform ligament, and you can see that there are three hepatic veins: 1, 2, and 3. See, right hepatic vein, middle, and left hepatic vein. Whatever, see these 7 and 5, 6 and 7 comes to the right of the right hepatic vein, like that. Okay, so the division of the quinoid segment is based on the 3 hepatic veins which drain to the IVC, and also the 2 branches of the portal vein. So the right lobe consists of 5, 6, 7, and 8. Which of the following statement is wrong regarding adult polycystic kidney disease? The kidneys are enlarged, the presentation is unilateral, intracranial aneurysm may be associated, typically manifest in the third decade. Here, the wrong answer will be the presentation is unilateral. See, adult polycystic kidney disease, ADPKD, is autosomal dominant, a genetic condition which affects both the kidneys in adults. So here, the presentation is not unilateral, it will be bilateral, and also the kidneys are enlarged. The intracranial berry aneurysms are an association of the ADPKD, and also there can be cyst in multiple organs, and typically manifest in the middle age, right, third decade. So the wrong thing here said is the presentation is unilateral. So next thing, contrast media and contrast media related adverse effects are very important in exams as well. Here, the question is actually very simple, but just learn the area, contrast media as well as contrast media reactions and its management. So after contrast media, it's not infection, it's injection, okay. After contrast media injection in the radiology department, a patient develops severe hypotension, bronchospasm, and cyanosis. See, the patient is developing severe bronchospasm, cyanosis, and hypotension, which means that the reaction is very severe, right? Which of the following drugs should be used for treatment? See, here the patient is going for severe anaphylactic reaction, severe allergic reaction, and patient is going for anaphylactic. So the drug of choice will be adrenaline, okay? Which of the following usually produces osteoblastic secondaries? We have already discussed in the previous session regarding secondaries. It can be osteoblastic as well as osteoclastic. Osteoblastic means it is bone forming. Since it is bone forming, it will be more dense, like it will be sclerotic in the X-rays. When there is osteoclastic, it will be lytic, and hence it will appear more lytic, means darker in X-rays. ഈ ഓസ്റ്റിയോബ്ലാസ്റ്റിക്കും ഓസ്റ്റിയോക്ലാസ്റ്റിക് സെക്കൻഡറി എന്ന് പറയുന്നത് they are metastasis towards bone. Okay, it is osteoblastic, osteoclastic എന്ന് പറഞ്ഞ ടേം വരുമ്പോൾ തന്നെ അത് ബോൺ റിലേറ്റഡ് ആണെന്ന് മനസ്സിലാക്കുക. And usually produces is what? Carcinoma prostate. Here you have to understand that this carcinoma breast and all also can cause osteoblastic secondary. Okay, carcinoma breastilൊക്കെ osteoclastic ഉണ്ട്, osteoblastic secondary ഉണ്ട്. More common will be osteoclastic, but here the question will be like, which of the following usually produces, means carcinoma prostate. Carcinoma prostate is the one of the most common carcinomas that produce osteoblastic, like that is sclerotic secondaries in the bone. Next question, the most common location of hypertensive intracranial hemorrhage will be. Hypertensive bleed can be caused in many areas, but the most common will be where? It will be in the basal ganglia. It will be in the putamen. Okay, most common area of hypertensive bleed will be in the basal ganglia. It can also happen in the brainstem, cerebellum, etc. But the most common area will be basal ganglia. Which of the following imaging technique is maximum radiation exposure to the patient? It's actually a simple question. The MRI, there won't be any radiation, so this is out. Barium studies are basically X-ray based studies. Either it can be static X-ray or it can be fluoroscopy. Whatever it be, they are barium studies will be X-ray based studies. So chest X-ray, CT scan, barium studies all will have radiation exposure, and definitely without any doubt, the CT scan will have the most radiation. Why? CT scan is actually X-ray based, and it is actually equivalent to multiple radiations. You might have already heard one chest X-ray is equivalent to say 300 or 350. I mean, one CT chest, CT abdomen is equivalent to 600 X-rays, etc. So CT scan, it is almost equivalent to numerous X-rays. So there are multiple. It is almost equivalent to multiple X-rays being exposed. So CT scan has the most reduced exposure. Okay. The procedure of choice for the evaluation of an aneurysm is actually the aneurysm means it can be fusiform or saccular outpouchings or dilatation of arteries. So the procedure of choice, actually many aneurysms can be diagnosed with most of these investigations. Some aneurysms can be diagnosed with ultrasonography, some can with CT, some can with MRI. But the procedure of choice among these would be arteriography. Why? Because an arteriography can diagnose as well as treat aneurysm at the same time. Hence, the procedure of choice, they are not asking investigation, any investigation or next investigation. This is the investigation or procedure of choice, which will be the arteriography. The common cause of subarachnoid hemorrhage is, you already know, the most common cause of subarachnoid hemorrhage will be aneurysm, which will be the biliary aneurysm. Many of these can actually cause subarachnoid hemorrhage. Arteriovenous malformation can cause hypertension, can sometimes cause subarachnoid hemorrhage, may not be directly, but sometimes can cause. But the most important cause will be aneurysm. Spalding sign occurs after. So what is the Spalding sign? Spalding sign is one of the signs seen in ultrasound after death of the fetus in uterus. Okay, Spalding sign is actually the overriding of the skull cranial bones of the fetus. Hence, Spalding sign occurs after death of the fetus in uterus. Okay. Next question will be named signs. You have to be very careful regarding named signs from the vertebral portion. There are actually many. Okay, there can be H-shaped vertebra. There can be this one spoon-shaped vertebra. There can be a Rugger jersey spine. There are many named signs from the vertebral X-ray, especially the lateral lumbar X-ray. So here the Rugger jersey spine, you can understand this is like white, black, white, black, white, black. This is Rugger jersey spine is most commonly seen with renal osteodystrophy. Okay, it is not dystrophy, it is dystrophy, renal osteodystrophy. Brown tumors are seen. This is actually many times people get confused. Just telling again, brown tumors are not actually tumors. They are actually a manifestation of hyperparathyroidism. Okay, in hyperparathyroidism, due to the altered calcium metabolism, there will be lytic lesions within the bones, which are called as brown tumors. So brown tumors are seen in hyperparathyroidism. Next one, gamma camera in nuclear medicine used for. Okay, gamma camera in nuclear medicine is an inevitable. In nuclear medicine, see, mainly actually not just two, but still two types of investigations are there. One is using gamma cameras, like SPECT or scintigraphy, usually say it as scintigraphy. And another one is PET scan. You might have heard in cancer evaluation, they are doing PET scan. Okay. In both the things, basically, the basic unit is gamma camera. Actually, we are giving one radioactive element into the body through IV route, intravenous route, and the organ will uptake either it can uptake or not uptake. However it be, the organ will uptake the radionuclides and it will emit gamma radiations. These gamma radiations are picked up from the gamma camera placed outside the body, which finally images. Actually, the gamma camera in nuclear medicine is not used for measuring radioactivity or monitoring surface contamination. Actually, it is just used for organ imaging. Okay, whether it is scintigraphy, SPECT, or it may be PET. Basically, it is used for organ imaging. How it is imaged? We give IV radionuclides, may it be technetium, may it be, say, FDG. These radionuclides go into the body, it will go into corresponding organ, and finally, it will it will actually measure the radioactivity, but it will be used for organ imaging by measuring the radioactivity using the gamma camera. Actually, this is a confuser. Basically, it is used for measuring the radioactivity, which is used for functional organ imaging. Okay. So among these, the best answer would be measuring radioactivity. This is also correct. Next is investigation of choice in patient with acute ureteric colic. Investigation of choice in patient with acute ureteric colic would be NCCT abdomen. See, this is an investigation of choice. Sometimes the patient will present acute ureteric colic. What is the next investigation? We will usually you go for ultrasonography. Nowadays, we usually go on for ultrasonography, and X-ray KUV is also somewhat correct, right? But when you say that the investigation of choice in patient with acute ureteric colic, investigation of choice will be NCCT abdomen. That is non-contrast CT of abdomen. Because why it is not contrast? Because there is no need for contrast, right? In the CT scan non-contrast itself, the calculi will be seen as radiodense, hyperdense structures, and also we can actually see the calculi, we can measure, we can characterize it to some extent, like we can give the HU values, Hounsfield values, which can be used for treatment. Hence, NCCT is the investigation of choice for ureteric colic, that is ureteric calculus. Okay. In a child, non-functional kidney is best diagnosed by. Actually, see, in a child, kidneys can be visualized with ultrasonography. To some extent, IVU can also visualize the functioning or non-functioning kidney. Because in IVU, in ultrasonography is just an anatomic investigation. Okay, it can just visualize the kidney. IVU can somewhat give an idea about the functioning kidney, because in IVU, non-functional kidneys may not take up the dyes, but the best investigation will be DTP renogram. It is actually a nuclear-based study. Okay. Now, the investigation choice for detection and characterization of interstitial lung disease is HRCT. Okay. For investigation choice for detection of and characterization of any interstitial lung disease or any lung parenchymal issues like say bronchiectasis, the investigation choice will be higher resolution CT scan or HRCT. A 40-year-old female patient on long-term steroid therapy presents with recent onset of severe pain in the right hip. Imaging modality of choice for the problem. This is an in-depth question. 40-year-old female on long-term steroids, hip pain. What are we suspecting? We are suspecting avascular necrosis of the femoral head. Avascular necrosis of the femoral head. Imaging modality of choice will be what? It will be MRI. Okay. So, steroid therapy is a risk factor. Being a female, steroid therapy, severe pain, right hip, we are suspecting avascular necrosis of the femur. Imaging modality of choice for AVN is MRI. Imaging modality of choice for avascular necrosis of scaphoid following trauma, maybe talus, everything will be MRI. So, investigation choice will be MRI among this. In treatment of papillary carcinoma thyroid, radioiodine destroys the neoplastic cells predominantly by. Okay. As we have already discussed, these gamma rays, alpha rays, X-rays, beta rays, all actually destroy cells, right? But in case of papillary carcinoma thyroid or many other treatment for cancers, including treatment of cancer using radionuclides like radioiodine. The ray which predominantly destroys the neoplastic cells are the beta rays. Okay, the radioiodine, that is the radionuclide of iodine, like iodine 131 or iodine 123, etc., produce beta rays that destroys the neoplastic cells. Which of the following statement is true regarding subclavian steal syndrome? Subclavian steal syndrome, you already know that subclavian and vertebral artery, vertebral artery being one of the branches, when there is an occlusion in the second and third part of subclavian artery, like when there is an occlusion before the branching of the vertebral artery from the subclavian, the vertebral artery, there is shunting of the blood through the vertebral artery from the opposite side from the other side to the ipsilateral side. Like when there is an occlusion in the right subclavian artery before the branching of the vertebral artery, there will be the flow to the limbs will be established from the ipsilateral vertebral artery. That is, there will be reversal of blood flow in the ipsilateral vertebral artery. So this is the true statement regarding subclavian steal syndrome. In CT, the attenuation values are measured in Hounsfield units. An attenuation value of 0 Hounsfield corresponds to water. Okay, Hounsfield HU is actually a calculation. It's actually a ratio. It's actually the unit is derived from the linear attenuation coefficient of the tissue and that of water, and the attenuation value is 0 for water. See, the equation is like Hounsfield unit of a tissue is equal to linear attenuation coefficient of that tissue minus that of water by the tissue. Hence, the linear attenuation coefficient, Hounsfield unit of water becomes 0. So the linear attenuation coefficient, the equation gives Hounsfield unit of a tissue, and that of water is taken as 0, and that of air is actually air and fat. That of air and fat is below 0. That it is denoted as minus, say minus 100, say minus 50, etc. And very dense structures and anything like soft tissue or any denser structures are above water, like plus 20, plus 30, plus 1000, etc. Okay, that of water is taken as 0. A 54-year-old male presents with features of obstructive jaundice. He also reports weight loss of 7 kg. That is significant weight loss in 2 months. On CT scan, the CVD is dilated till the lower end, and the main pancreatic duct is also dilated. Pancreas is normal. The most likely diagnosis is, see, the patient has obstructive jaundice. That is, there is some issue with the bile flow. The patient has significant weight loss. So we are usually suspecting what? A malignancy. CT scan, CVD is dilated till the lower end. CVD is dilated till the lower end, and the main pancreatic duct is also dilated. Naturally, what we will consider, first BD would be carcinoma head of pancreas, right? But they say that the pancreas is normal. Then the only possibility is what? Periambulary carcinoma, like in the periambular region, that is 1 centimeter within the ampulla of Vater. There can be lesions that will cause the same picture. The first one will be head of pancreas malignancy. Actually, in periambulary carcinomas, right, head of pancreas is also included, but still here, since they say that pancreas is normal, the only option will be periambular carcinoma. Hilar cholangiocarcinoma will be in the hilum of the liver. It is higher above. Carcinoma gallbladder is also higher above. Cholelithiasis means it is just what? Stone within the CVD. There is no need for pancreatic duct to be dilated. Okay. Now, the patient who had a road traffic accident presents with a loss of consciousness. CT shows multiple spotty hemorrhages and full basal ganglia cisterns bleed. And so, what is the answer? CT shows multiple spotty hemorrhages. Usually, what we see is there we can see parenchymal contusions as large hemorrhages. You can see extraaxial bleeds like extradural hematoma, subdural hematoma, etc. But here they say that multiple spotty hemorrhages. Actually, multiple spotty hemorrhages is seen in diffuse axonal injury. Diffuse axonal injury. The thing is, many times diffuse axonal injury may not be detected in the CT. Diffuse axonal injury, like sometimes multiple spotty hemorrhages are seen, then we directly diagnose diffuse axonal injury. Sometimes the CT appears relatively normal, like we are not seeing much of an issue, and even if we are seeing some findings, that findings may not correlate directly with the patient's clinical condition. So in such cases, we suspect diffuse axonal injury and we take MRI scans, which gives the diagnosis. Okay. So here the answer will be diffuse axonal injury, and full basal cistern bleed might be due to subarachnoid hemorrhage. Okay. Next, best investigation for temporal bone fracture is temporal bone fracture. The best investigation will be CT. For assessment of bones, mostly the best investigation will be CT, except for some conditions where MRI is used, like bone edema. In case of fracture, the best investigation will be CT. In temporal bone fracture, we usually take high resolution CT, HRCT temporal bone. Tumors showing dural enhancement with a tail. Okay, what is dural enhancement? Dural enhancement is actually a reactive enhancement of the adjacent dura lying adjacent to the tumor, and it produces a tail. So the most important thing will be meningioma. Actually, there can be dural enhancement in some of the lesions like glioblastoma and all, but usually when you say if you have to pick one, it will be meningioma. A neonate presents with congestive heart failure on examination, enlarging fontanelle, bruit on auscultation on UST shows midline hypoechoic lesion. See, actually, this is a very confusing question. We have not mentioned anything significant. Where is the bruit? Okay, where is the bruit? Where is the ultrasound done, etc. So here, first thing is it is a neonate. The patient has presented with congestive heart failure. There is heart failure for some reasons. On examining and enlarging fontanelle is seen. Fontanelle means what? Anterior fontanelle. Anterior fontanelle is seen means something intracranial is happening. There is bruit on auscultation. Bruit on auscultation, where from the fontanelle we are able to hear bruit on auscultation. That means there is a high flow state. Something is flowing inside. Obviously, blood will be flowing. And on ultrasound, what is this ultrasound? It's actually NST, neurosonogram. Shows midline hypoechoic lesion. Midline hypoechoic lesions, which is showing increased blood flow. It is actually a malformation of the vein of Galen. Okay. It is the vein of Galen. Vein of Galen is actually a congenital anomaly. Congenital anomaly, it is actually the pathology. I'm not going deep into the pathology. This is actually due to the persistence of the median prosencephalic vein, which is causing a direct communication with the embryonic artery and veins, which actually directly shunts the blood to the heart, which results in cardiac failure. So when such a question comes, always remember that the answer will be malformation of vein of Galen. Next is just another introduction to some interventional radiology part. The material used in vertebroplasty. So what is vertebroplasty? As the name suggests, it is some intervention done in the vertebrae. It is actually what happens whenever there's a vertebral collapse. So whenever there's a vertebral collapse with pain, etc., we usually somewhat reconstruct the vertebrae by injecting some material that is the polymethyl methacrylate, PMMA. We inject this material to the vertebral body with a needle. This is terms vertebroplasty, and the material used is PMMA, polymethyl methacrylate. Gold standard test for diagnosis of acoustic neuroma. You know that acoustic neuroma is like also called as vestibular schwannoma. It is a nerve sheath tumor, intracranial tumor. Hence, intracranial tumor itself, you know that it is MRI. Okay, mainly it's a posterior fossa tumor. It is an acoustic neuroma. It is a tumor of the nerve. You might have already heard that this one there is a typical appearance like ice cream cone appearance, etc. This is actually seen in MRI. So next will be PACS. PACS in medical imaging stands for just it is like picture archiving communication system. PACS. Actually, what is PACS? In previously, conventionally, what we use, we give X-ray films to the patients for the clinicians, etc. Nowadays, we are actually changing to digital formats. And PACS, that is picture archiving communication system, is the technology we use for archiving images. Okay. We'll go for a few more questions. I think I am running short of time. I mean, there is a lot to finish. So I'll slightly rush. Okay. Which of the following is true about chest X-ray? Right hilum is lower than the left hilum. Right dome of diaphragm is lower than the left. Pulmonary artery is normally extend the periphery. All of the above. So actually, right hilum is lower than the left hilum. It's actually true. In chest X-rays, you can see the right hilum is slightly lower than the left hilum. Next thing is the right dome of diaphragm is lower than left. Actually, no. See, the left dome of diaphragm is lower. Actually, the cause is the heart is sitting on the left side. That is why the left dome of the diaphragm is lower. It is not because the right side there is liver. Okay. Right side is upper, left side is lower because left side the heart is sitting. Pulmonary arteries normally extend up to the periphery of the lung. No, pulmonary artery do not extend up to the lung periphery. I mean, they cannot be seen. They might be extending. It has to perfuse, right? But it is usually not seen in the X-rays. Pulmonary arteries are seen in the peripheral region in pathologies. So okay, another popcorn calcification. The answer will be what? It is chest X-ray. Some opacity is there. Some calcification is there. In the CT cross section, there is a lesion shows peripheral calcification. I mean popcorn calcification, coarse calcifications. These coarse calcification, similar calcification we saw in the breast previously. It is classically seen in pulmonary hematoma. So popcorn calcification in breast, involuting typical fibroadenoma, popcorn calcification in chest. It is pulmonary hematoma. So early change of pulmonary edema in chest X-ray will be what? It will be the curly lines. Okay. Earliest change of pulmonary edema in chest X-ray will be curly lines because this ground glass appearance, this pleural effusion, which will be later findings. Curly V lines, these are the lines. Okay. See, curly lines are basically due to engorgement of the septal lines. You might have heard of interlobular septae, which are the functional units of lung parenchyma. So the interlobular septae or interstitial septae of the lung engorges due to many reasons. It can be due to cellular infiltrates, it can be due to edema, it can be due to hemorrhage, etc. So in pulmonary edema, actually what happens, the lymphatics, the drainage system, the interlobular septae becomes thickened and it appears as curly lines. Okay. Please read about curly lines. There are curly A, curly B, curly C lines. There are actually everything is more or less the same. They are thickened interstitia, but still curly A is, there are differentiations like curly B lines are more peripheral. They are like this. Curly AA lines are more in the towards the hilum. They converge towards. Curly C lines are like this. So there are some differentiations, but still all pulmonary edema. In case of pulmonary edema, the first finding will be curly lines. Now, investigation choice for a pregnant lady with upper abdominal mass will be what? C. CT, DSA, no. Barium meal, no. MRI. In case of a suspected upper abdominal mass, the investigation of choice will be what? MRI. Here there is no ultrasound as a confuser. But if you say that the next investigation in case of a suspected upper abdominal mass in a pregnant lady, the next investigation will be an ultrasound. Okay. Ultrasonography is not useful in, okay, what? Breast cyst. Breast cyst, it is useful, right? In many cases, breast in investigation of choice would be ultrasound because many cases, breast cystic lesion and solid lesion can differentiate. So breast cyst, ultrasonogram. Ascites, yes, because even mild fluid, minimal fluid can be diagnosed with ultrasound. Hence, we are taking EFAST now for trauma, because we can diagnose minimal fluid. So ascites as full blood rest. CVD stones, it is actually difficult to visualize CVD stones when it is distal because of the bowel gas obstruction and other structures. So ultrasonogram is, we cannot say that it is not useful. Maybe like it is less useful in CVD stones. Characteristic of benign tumor of lung in X-ray. Okay. It will be, there are many characteristics, like there is no hard and fast rules regarding benign tumors of lung in chest X-ray, like benign and malignant. But still, usually what we see is in malignant tumors, the size will be large. There can be cavitations due to necrosis. There will be there can be peripheral location. There can be peripheral calcification. There can be punctate calcification. But concentric dense calcification is actually a feature of benign tumor. It is usually, in case of concentric dense calcification, it's usually seen in granulomas. Okay, it is actually a feature of benign tumor. Next is extradural hematoma. We have discussed in the previous session also. Just this question for a reminder. Okay, extradural hematoma is usually seen as a hypertense biconvex lesion. The important thing is this biconvex, like a lens-like shape or crescentic shape, it can be confused when just an image is given. In the previous exam also, I think some subdural hematoma and extradural hematoma, there was a confusion due to the image. But just keep in mind, extradural hematomas cannot cross sutures because it is extradural. The dura is strongly attached in the sutural areas, hence it cannot cross sutures. And also, usually, it is an arterial bleed due to direct trauma. There can be associated fractures also. In subdural hematoma, it will be crescentic. It can cross sutures, but it will not cross. Usually, it will not cross midline. Extradural hematoma is the other way around. It cannot cross sutures. Pipe stem appearance in barium enema is seen in. Okay, pipe. This also we covered in the previous one. This is a barium double contrast barium enema picture showing the entire column beautifully. Pipe stem appearance. Actually, what is pipe stem? Pipe stem is just like a pipe. Okay, the appearance is just like a pipe. See, what is this pipe stem appearance? You know, in normal colon there will be hostrations. There will be hostrations like this. Hostrations like this. When the hostrations are lost, it will appear like a pipe. It is seen in ulcerative colitis. Pipe stem appearance in different ulcerative colitis due to the loss of hostrations. Next is double bubble sign. We have already discussed the previous one. Double bubble is, one bubble is the stomach. Next bubble is the duodenum. Double bubble is seen in X-ray abdomen in an infant. Is seen in what? Distal, I mean duodenal obstruction. So here the answer will be both. Duodenal atresia is the first answer. It can also be seen in annular pancreas. Okay, annular pancreas also obstructs the duodenum in the second part. Hence, both the bubble. Investigation of choice to demonstrate vesico-ureteric reflex. We have already covered. There is a confusion here between IVP and MCU. Vesico-ureteric IVP, what happens? We give intravenous dye. The dye gets excreted from the kidney, reach the ureter, reach the bladder. That is IVP. But see, vesico-ureteric reflex is reflex of the urine from the urinary bladder. It cannot be diagnosed with IVP, okay? It is done with MCU. That is micturating cystourethropy. In micturating cystourethropy, it is the other way around. In micturating cystourethropy, the contrast is filled in the urinary bladder through a Foley catheter, and the patient or the child is asked to void. And when child is asked to void or in full bladder, if there is reflex, the ureter and the pelvic calcium system will be contrast opacified due to the reflex. It is not the other way around. So it is not IVP. In IVP, the kidney is excreting and it is coming to the bladder. It cannot demonstrate reflex from the bladder. In MCU, the bladder is filled first using a Foley catheter. You can see the Foley bulb here. And then after on maturation or in full bladder, there will be a reflex which shows the ureter and pelvic calcium system. So for vesico-ureter reflex, MCU. Next, the sun-ray appearance on X-ray. We already dealt with sun-ray appearance of X-ray is basically due to what? It is due to the periosteal reaction. It is actually the periosteal reaction associated with a malignant tumor. Actually, sun-ray appearance എന്ന് പറയുന്നത് എവിങ് സാർക്കോമയിലും ഓസ്റ്റിയോജനിക് സാർക്കോമയിലും കാണാം. But it is classically described for osteogenic sarcoma. Okay, the classical sun-ray appearance of periosteal reaction. See, this is a spicules. This is a sun-ray appearance. See, is seen in osteogenic sarcoma. In Ewing sarcoma, the classic appearance is onion peel appearance. Okay. So best position for chest X-ray previously discussed. Actually, if it's a left-sided pleural effusion, it should be the left lateral decubitus. There will be leveling of the fluid. Next one, ring enhancing lesion on a brain scan usually suggests. The thing is, ring enhancing lesion, there are multiple lesions of the brain which can produce ring enhancement. Ring enhancement means that this peripheral enhancement is termed as ring enhancing. Okay, there are multiple lesions. So all of the above the answer here. It can be seen in abscess, mets, glioblastoma, etc. So this is actually what a ring enhancing lesion on brain scan എന്ന് പറയുന്നത് usually what we refer to is MRI brain. It can also be seen in CT, but we refer to ring enhancing lesion mainly on MRI of the brain. So the answer is all of the above. There are multiple lesions. Actually, it can be cerebral abscess, it can be in tuberculoma, neurocystic sarcosis, metastasis, glioblastoma, and there are many other things. But at least this area, keep in mind: cerebral abscess, tuberculoma, metastasis, glioblastoma, neurocystic sarcosis, and among these two. Okay, always keep in mind. Next, ideal imaging modality to diagnose hydrocephalus in a 1 month old. 1 month old, ideal imaging modality to hydrocephalus is actually ultrasound. Okay, you can do an NST neurosonogram in a 1 month through the anterior fontanelle, and we can diagnose hydrocephalus. But the next investigation, following an NST, there is suspicious hydrocephalus or there is hydrocephalus. The next investigation would be MRI. Why? Because we have to find out what is the reason for hydrocephalus. Next question, medullary cystic disease of the kidney is best diagnosed by. Straight away question, kidney medullary cystic disease, multiple cysts in the kidney, best diagnosed with ultrasound. Prominent left border of the heart is formed by all. Actually, mediastinal borders we had discussed in previous thing. You see, prominent left heart border is seen. It is seen with pericardial cyst, no? Pericardial cyst, coronary artery aneurysm, left auricular aneurysm, everything can cause prominent left heart border. But azygous vein is placed on the right side of the mediastinum, right? So azygous vein, when prominent, cannot, basically it is above the cardiac shadow itself. So azygous vein when prominent or azygous vein when visualized, it doesn't add to prominent left heart border. So here the answer would be azygous vein. Next, the best view for visualizing sella turcica. Sella turcica means sella turcica is the cavity where the pituitary gland is placed. The best view for visualizing the sella turcica will be a lateral view of the skull. So the sella turcica view will be a lateral view of the skull. So investigation choice for small intestinal tumors. So small intestinal tumors, actually many like barium meal or barium meal follow through or CT scan with contrast, etc. are actually investigations for small intestinal tumor. But the investigation of choice now will be CT scan with contrast. It can also be said as CT enterography. CT enterography. Okay. All are seen in left atrium enlarged and extract. So it is like others are seen. One of them is not seen. See, posterior displacement of the esophagus on barium meal. When the left atrium is enlarged, the left atrium is in very close contact with the esophagus. So when left atrium gets enlarged, there will be posterior displacement of the esophagus on barium meal evaluation, especially best seen in lateral images. And there will be straightening of the left main bronchus. There will be straightening of the left heart border sometimes, and there can be double shadow of the right atrium. When left atrium enlarges due to its particular position, there will be double shadow of the right atrium. But see, retrosternal lucency on lateral chest X-ray. When there is a lateral chest X-ray, there is nothing in the retrosternal region, right? When the left atrium is enlarged, retrosternal lucency is there is nothing to do with retrosternal lucency. So here the answer will be retrosternal lucency on lateral film. Now, next is medusa head appearance abdominal X-ray. Actually, we discussed previously. It is due to roundworm. Medusa head appearance, multiple entangled appearance of the hair, of particular appearance of the hair. It is due to roundworms. Then radiological findings in meningioma, except there can be, this is also previously discussed. It is calcification is there. Meningioma, in one of the lesions, it is one of the lesions that can produce intracranial calcification. So meningioma is there, calcification is there. Vascular markings become more prominent. There can be osteosclerosis. That is, there can be hyperostosis of the adjacent calvarium in meningioma. Hence, the none of the above will answer. So thank you. We'll finish this. Thank you.